I know there's staff shortages. There's all kinds of scenarios where you might not be able to do this, but you should periodically go out and ask each and every patient whether their condition is deteriorated or they feel worse or whatever it is, because their patient's condition can deteriorate to an emergency medical condition and they need to get back stat. Sometimes you can't do that. Best practice would be try to monitor your patients as well as you can. Talk a little bit about where EMTALA doesn't apply. We know if there's no emergency medical condition, EMTALA doesn't apply. I don't care whether they say you don't have a proper ED log. If you determine that the patient's stable, EMTALA doesn't apply. Will they cite you for it? Sometimes, but normally we can get those situations removed. We talked about admitting as an inpatient. I call him Judge Wacko in the Sixth Circuit because he believed that a patient in an ambulance was subject to EMTALA. Not coming on the hospital's property, whatever it is, he just thought that was good practice. That case hasn't been overruled, so I say in the California and in the 6th District, and I think, well, no, it's a Michigan case. EMTALA may apply to ambulances, but nothing to really be concerned about. Provider-based entities, urgent care centers. We can talk about that for a little bit. Interesting background because CMS, it used to be called, who can remember it being called HCFA? I used to say the acronym stood for Here Comes Further Aggravation. That's exactly what it is. Well, here, the government decided to define it as dedicated emergency department. And there's specific requirements. You're either licensed or you qualify. And so the term is DED. But originally, they had another little letter in there and it was DEAD. And they decided that wasn't really too good of an acronym to follow in that practice. But certainly individuals presenting and they come in the emergency department and they ask for, where's the pharmacy? Where's the lab? Question is, are they presenting for a medical condition? Normally, they're not going to be. So a patient asking for directions to the lab, to the inpatient unit is not going to be someone coming in for the treatment of a medical condition. So those kinds of cases are pretty clear-cut. Where it's not so clear-cut and is not a good practice is, let's take our patient in the physician office. And the patient needs a CT scan. So the physician tells the patient, go to the hospital's emergency department and just wait there for me. I'll be there as soon as I can. Has the patient presented to the emergency department? You doggone right he has, or she has. It's not a good practice because I'll have hospitals tell me, it's common, those doctors will put them in another room and they'll come and see them. Wait a minute, they forgot the primary principles of EMTALA. You should log them in. You should do a medical screening exam on that patient. There may not be anything there, but at least you've got documentation in case that patient goes south. A lot of the docs don't like it. Sorry, I'm just telling you, you're going to be subject to a patient that may be dying and you haven't done any screening exam. You might be on the hook, and I don't want that to happen. It's better to be able to log them in than not log them in.
Hey Cliff, what about the patients who, like, the doctor sees them over in the clinic setting and then says, you're really sick, we want to transfer to a higher level here. Can you ever transfer from the clinic setting to, like, Peoria or Springfield or wherever they may
if the clinic is not subject to EMTALA, then the physician can send them anywhere they want to go. Okay? Best practice is not necessarily to do that. But here again, that's not an EMTALA. That may be a hospital policy or best practice. If the clinic is provider-based, well then I didn't ask enough questions, did I? Because it's provider-based, EMTALA does apply immediately in those types of circumstances. So that physician must follow the appropriate transfer requirements. Accepting hospital, accepting physician, appropriate facility. Yeah, all the elements of an appropriate transfer attach to them as if they were in the emergency department. Yes?
Well, are you referring to what Dr. Jones was saying, asking earlier then, when he was saying if he had a patient in his office and he recommended they come to the hospital for the rehab? That would,
I indicated I broke it in two parts. One, if he's a private physician.
but is he a provider-based? All of ours are provider-based.
Okay, well, so then when I said if you're a provider-based department, then EMTALA applies. So if your physicians are all in provider-based departments, EMTALA applies to you.
Well, I'm going to tag on to what he was saying though.
Sure.
If the patient chooses to come back to the vehicle, we know they're coming, they might not come for an hour and a half, 2 hours, they've just gone home, took a shower, and fire, kids' beds. So should we be having them sign a paper stating that you should go directly, and if they choose not to, that comes back on them?
How is the physician going to order that?
What?
Order to go to the emergency direct admit?
Just recommend.
Yeah, okay, so there's going to be some documentation in that record. But that doctor should also say you need to go within 15 minutes, or you need to go by ambulance, or there's specific, I don't want to say discharge instructions, but disposition of the patient. There needs to be instructions there so you have documented if she goes home and doesn't come for an hour and a half, you've given me a defense. Okay, if the situation is dire, then what are you going to do? You're going to call that ambulance. I tell you, a lot of hospitals, they want to have crash carts go out. I know it doesn't apply here, but I'm not going to put hospital staff in harm's way by running to a private physician office with a crash cart when there's 6 inches of snow on the ground and it's dark and you want to call that ambulance and get that ambulance here so they can get them, even if it's to the emergency department. If they decide not to, you better have an AMA form, because all the forms that apply in the emergency department also apply in the provider-based physicians' offices. Yep, you better have those AMA forms. You better have left without being treated. You've got to have the documentation to defend against an allegation that you didn't get the proper treatment. Those are good questions, by the way. Yes, ma'am.
Senator, it's a real life case quite a few years ago. We have other people do OB coverage, like Macomb, Celtic, whatever. So a patient was not our patient, wasn't in our care, but just happened to stop by the hospital. She was in early labor. It wasn't anything that seemed like an emergency, very healthy, low-risk patient. And she wanted to deliver a kill gun. And she was probably in early labor, but that's sometimes kind of hard to assess.
Mm-hmm.
And so we said, well, you could stay here, you could go to your hospital. So she says, well, I'm going to go to the hospital who's doing my OB care. So we said, okay. So the patient didn't show up to the other hospital for 6 to 7 hours though. She went home, hung out, did early labor, whatever. When she went to the other hospital though, she was in active labor, and she also happened to be a breech. So there was a medical exam. The patient left by choice. She didn't go by ambulance. So what do you do in a case like that?
Wow. Does everybody hear the question?
AMA.
Okay. I'm glad you tacked on, because I was going to ask you, did this hospital do a medical screening exam? What was the determination of the medical screening exam?
That she was really not really admittable. We'll have
And we
patients
didn't-
come in at 2, go home, come back, when they're more active. So she wasn't really in active labor. And she was a low-risk patient. wasn't a problem. And she wasn't really our patient, she just stopped by here.
I don't care whether she stopped by, walked by, or whatever it is. When she's here, you got to do the screening. What I'm looking for is a determination of whether that patient or the unborn could be in an emergency medical condition. That is a physician's judgment, or the nurse practitioner, followed by the certification of the physician. If it's determined, and it may be a malpractice, but if it's determined that patient is stable, you're okay.
So should she have signed something? Like, we really thought she was going directly from point A to point B.
If you were calling me as the risk manager or the attorney, I would definitely say, I want you to provide documentation of what you advise the patient to do.
We did.
And if you have that, it's a defense. Doesn't mean that you're not going to be subject to a violation. But what I don't want to hear is the cases so many times happens. Private vehicle will pull up to the emergency department. A nurse will go out, do an assessment, realizes that the patient is in deep trouble, and sends the patient in the car to the hospital. It happens all the time. If the nurse isn't a qualified medical person, then he or she can't make that screening exam fit. You got to bring that patient in, or the doc has to go out and do the screening exam.
The screening exam is really not necessarily a physician, it can be an advanced practice nurse or.
If the hospital's bylaws and rules and regs permit those individuals, because even social workers can be QMPs, qualified, because they're capable perhaps of determining a psychiatric emergency, which is defined as a threat to themselves or harm others. So, but it has to be written down so that when the surveyors come in, has there been an appropriate medical screening exam?
I have a question. So, in our clinic, it's a specialty clinic, but it also does urgent care at later hours of the day.
No, it does walk-in, it doesn't do urgent care, it's
Well,
different terminology.
Okay, walk-in. So somebody walks in the clinic during the 8 to 5 when it's only specialty doctors there. There's nobody there qualified to triage a person who just walks in the door, but yet they really shouldn't be walking out the door. They should be seen by somebody. What do we do with them?
So is the clinic provider-based? You know the answer to it. They got to do. They're subject to do that screening,
Even
and if
they're
that,
not qualified to do it. I mean,
well,
one's pediatrics, one's OB/GYN.
the thing about it is, you got to have a QMP in that particular department to make that assessment. If you don't, you can't properly assess the patient. You may have to wait for somebody to come, and if the qualified, I mean, an RN can be a QMP.
And what if there's not an RN in that staff?
So a heart attack person comes in, there's an OB and a peds. What do you do for them?
Physician?
There's still physicians.
Yeah.
Yeah, they gotta be-
You're doggone right. Yeah.
So
Phys-
then the OB,
Yeah.
They might not know how to fix it, but they know what to do.
calls 911 and that's
Right.
okay.
Yeah, yeah. No, when those situations, we talked about physicians, they got unlimited license to practice, then they can make a determination. I don't want to say it's brain surgery, because that may be wrong, but they can make that decision and make sure that they do the assessment, even if it's the start of it, until they get to the ED. But you better have documentation about how they're going from point A to point B, okay?
In the case there's another physician in office,
If there's not a physician in office,
can the nurse?
if the nurse is designated to be a qualified medical person, you can. It's a funny thing, with physicians in the ED, not here perhaps, emergency department physicians don't want nurses to be qualified medical persons. They're the ones that make the determination. But you go to the OB department, and the OB physicians are going to say, yeah, I want my nurses to be qualified medical persons. If you're going to do that, you have to specify qualifications, whether they're in the emergency department, nurse practitioner, PA, RN. You want to have experience, training, background, competencies, evaluations. You want to make sure that they're qualified to be able to do that. You don't want to have a first or second year nurse come in the emergency department and be a QMP. you need to specify that they fit into those categories of requirements for qualified medical persons.
So I'll tag on what she was, I think, getting at is, so the providers are on vacation, but the office is still open. Somebody presents for medical care.
You better have backup. You have to have backup, and it better be written. If it's not written, you're subjecting yourself to, now your backup may be having maybe the emergency department physician come to that particular clinic, but you need to have some kind of resource, because that chest pain in a provider-based clinic, I guarantee you're going to be fined every time.
So would a Good Samaritan law work if the clinic staff provided basic first aid, called 911, and did all that kind of stuff? If they walk into the office, providers on
I won't,
vacation,
yeah, I understand. I won't apply Good Samaritan in that case, but what I would apply, because you mentioned magic words, ambulance, 911, call the emergency department, get that patient over there. I can defend that issue. I cannot defend it if you don't have any backup procedures.
if somebody comes in presenting for a cold, non-emergency, they can be safely turned away if there's no provider in the building.
Not without a qualified medical person making that assessment. That's why it's important to have nurses be qualified medical persons, because it's those easy cases, those colds, those little stitches, you want that person to be assessed and rule out that that's an emergency medical condition. Now, some doctors are not comfortable with that. I'm going to try to wrap it up here because there are a couple of things that I want to cover. If a patient is admitted as an inpatient, the Medicare conditions of participation apply. So, if the right hand EMTALA doesn't get you, the Medicare conditions of participation will get you. And you'll get this letter that says, ABC Hospital will be terminated on such and such a date. Nobody wants to receive that. The ones that are directed to it are the governing body. And I guarantee you, as a surveyor, they'll go to the chairman of the board and say, why aren't you doing this? Why aren't you disciplining? Why aren't you enforcing your own policies and procedures? This is the enforcement process. There's a whole bunch of cases that I've illustrated in the handouts, but that's spaghetti right there. So you have an EMTALA violation. Surveyor comes in, prepares a survey report and their findings. Remember, for a hospital with over 100 beds, it's $50,000 per violation. Less than 100 beds, only $25,000 per violation. So the process goes like this. You get a survey report and the findings. Doesn't matter what you respond, okay? The QIO may be called upon. That's a separate request from CMS. So if you have a neurosurgeon that doesn't come in, you're going to have a neurosurgeon on the government side questioning that physician, why did you make those clinical judgments? They make a report. The two reports then can go to accreditation, any accreditation organization. It may result in revocation of your accreditation. But here's where it goes with those two combined reports to the Office of Inspector General. And those folks play by different rules. You have 90,000, 200,000, 52,000. They're the ones that impose the civil money penalties. They can exclude providers. CMS can't exclude providers. The OIG can exclude. In other words, their remedies are draconian. And you know how you settle a CMP fine with the OIG? You bet against yourself. They'll say, it's a $100,000 fine. Come with this, with an offer. So you come and you say, 20,000, and they'll say, not good enough. They won't come back with another offer. You just keep going up the line. Imagine OCR is Office of Civil Rights. If you have a question with regard to discrimination, for example, the Nevada hospital that examine psychiatric patients. You know what they did? They screened them okay. They determined that they needed psychiatric care. So what did they do? They gave them a one-way ticket on a bus, a sandwich, and shipped them off to California. Office of Civil Rights didn't take kindly to that at all. Not only EMTALA, but they had multiple agencies. I just don't know how that can happen, but it happens. Let's see. So this is kind of a termination letter. It's kind of two-part. One, it says you violated EMTALA, but then there's there's a reference that they believe that there was some discriminatory practice, and they referred it to the Office of Civil Rights. I thank you very much for your attention and your questions. I'm here to answer any questions, but before you go, I want to make this recommendation. If you had a question that you did not want to ask, you could submit it anonymously to Nancy. Please do, because there may be a practice like the one I had that said, we always escort the patients to our OB department. 6 or 7 sessions. He said, always. The CEO was in one of the sessions. The nurse said, wait a minute, no we don't. CEO congratulated and commended that nurse for making that assessment, because what potentially did it do? It safeguarded the patient. And so if you have a question, give it to Nancy. I'll help her, whoever she wants to have help for, and I'll end it on the note, I don't want to have any harm caused to the patient. I thank you.
Thank you.
You're welcome. Thanks. How are you too?
Where's EMTALA?
I want